Okay, Chapter 5, debridement. Before we get started on Chapter 5, I understand there was a question about the clock position and that someone had quoted or had referenced the book and correctly. That is correct. On page 47, you will find that the clock position, the 12 o'clock position, is assigned to the part of the wound located closest to the patient's head. Now, the one caveat to that is if that doesn't make sense. Let's say that you're on the inner thigh at the gluteal fold. It may not make sense for the part of the wound closest to the head for you to use the part of the wound closest to the head. Maybe you'd use the part of the wound closest to some other structure, or maybe if you're on the back of the thigh, use the wound closest to the patella or the lateral malleolus or the medial malleolus. So if you use the clock position where the 12 o'clock is pointing anywhere other than the part closest to the head, then you do need to document that as your reference point. It's not wrong, it's just that you must put that in your documentation. So if you find putting the 12 o'clock, anywhere other than the part that is closest to the head, you must reference it in your documentation. Okay, let's move on. Here's our objectives for Chapter 5. We're going to talk about using the red, yellow, black descriptions of wound bed characteristics to look at how or what our intervention should be. We're going to differentiate between sharp, autolytic, enzymatic, mechanical, and surgical debridement. We're going to explain the indications and contraindications for autolytic debridement, enzymatic debridement, mechanical debridement, and then we're going to set some appropriate debridement goals for patients with necrotic wounds. So let's start with the larger categories of debridement are broken down into selective and non-selective debridement. So when you're talking about selective debridement, you're really talking about some specific types of debridement. And the types of selective debridement that we talk about that are referenced in the book are sharp, enzymatic, and autolytic debridement. As we go through this chapter, you're gonna learn what each of those means and why they're selective. And then the other type, the larger category of debridement that we have is non-selective. And non-selective is really mechanical and surgical debridement. Again, we're going to be more specific as to why those are non-selective and why sharp, enzymatic, or autolytic is selective as we go through. So first of all, let's talk about the purposes of debridement. There are 7 definitive purposes for debridement. The first one is to decrease the bacterial concentration within the wound and the risk of infection. So I had said this a little bit earlier when we talked about a blister. If it pops and you have that layer of skin over the top, I had said you need to clean it off, you need to debride it off, because that is a magnet for bacteria to breed in. Necrotic tissue, any kind of dead, non-viable tissue, is the same thing. It is just an excellent medium for bacterial growth. So you want to debride it off, you want to debride it out of there so that bacteria doesn't have a place to grow. Secondly is debriding increases the effectiveness of a topical antimicrobial. If I put a topical antimicrobial on a non-vitalized tissue or necrotic tissue, all I'm doing is I'm killing or trying to kill whatever bacteria might be on that non-vitalized tissue. But as we just talked about, non-vitalized tissue is a breeding ground for more bacteria. So if you can debride that tissue off, then put the topical antimicrobial on, you're going to get it on the red granulation tissue and you're going to kill the bacteria at that level versus having this layer of dead cells between the healthy tissue and and what you're trying to get to. So number 3 is we want to improve the bactericidal activity of the leukocytes. Again, if the leukocytes, the body's own protective or natural system, has all of this necrotic devitalized tissue to go through, it's going to decrease the activity of the leukocytes, because again, you're think of it as kind of a wet blanket over granulation tissue. If you have this wet blanket over this tissue, the leukocytes are trying to maintain a healthy granulation tissue, but have this barrier, this layer of devitalized tissue in between the granulation and their activity. So by debriding that off, you really improve the activity of the leukocytes, and therefore the body's immune system, or the body's own ability to turn over, to advance the wound healing. We had talked about this a little bit in the very first chapter, and so you're going to see here where it really kind of comes back to talk about what is a normal phase, with a normal continuum of wound healing. So that goes right into number 4. Another purpose for debridement is to shorten the inflammatory phase of wound healing. One of the things we had talked about, again in chapter 1, is that the inflammatory response is to rid the body of necrotic tissue, foreign material, cellular debris, that kind of thing. So remember, we talked about inflammatory phase is the very first phase you get, and it's because the body wants to get rid of all the devitalized tissue. If you have devitalized tissue constantly on the wound bed, then you're going to have that constant inflammatory phase, because the body is kind of churning and trying to clean that up. If you debride that devitalized tissue off, then you're going to shorten that inflammatory phase. Therefore, you're going to allow that wound to heal, to move through each of the phases of wound healing that we talked about in the very first chapter. So that's a really important point. Number 5 is it just decreases the energy required by the body for wound healing. All these other things that I've talked about talks about how the body is trying to get rid of devitalized tissues, trying to decrease that bactericidal effect. You've got the leukocytes that are churning there. You've got the inflammatory phase of wound healing. You've got all this going on as the body tries to heal itself. The longer that necrotic tissue or devitalized tissue stays on top of that wound, the more energy the body's going to require to churn and continue to try to clean it up. If you debride that devitalized tissue off, you immediately decrease that energy, because the body doesn't have to take care of that. It can move on towards moving through those phases of wound healing. Number 6 is to eliminate the physical barrier to wound healing. I talked a little bit about this last night when I talked about when you're looking at slough and eschar and that kind of thing on a wound. Remember, I said you cannot determine the depth if you've got slough or eschar covering a part of that wound. You can't determine the true depth because that eschar, that slough, is a physical barrier to you knowing what that wound looks like. Well, for the same reason, if you have that eschar, that slough, even a scab, it creates a barrier so that the epithelialization, we talked about how the epithelial cells, once you have the granulation tissue is there, then the epithelial cells will start to migrate from the edges. Remember, we talked about contraction, we talked about epithelialization and how they migrate from the edges. If there's devitalized tissue there, that's actually a physical barrier. Epithelialization will not happen over devitalized or necrotic tissue. It will not. So that is a physical barrier to wound healing. And then last, but certainly not least, is by getting rid of the devitalized or necrotic tissue, you decrease the wound odor. Wound odor is pretty significant for patients. No one wants to have this odor emanating from them. It's a source of embarrassment for the patients. It's a source of embarrassment for the caregiver. It just socially is something that's really a negative for the patient. So debridement helps decrease that wound odor in that wound bed. So the general indications for debridement are you want to get rid of necrotic tissue, you want to get rid of any foreign material. Generally, when I talk about foreign material, let's say that you slid your bike down a gravel road and you got little pieces of gravel and dirt in there. That's foreign material. Let's say that a patient's had a surgery and you see that there is there's a little stitch left in there. That's a foreign material. So debridement is to get rid of any kind of necrotic tissue, foreign material, or any other debris that you see in the wound. Occasionally or possibly you also want to get rid of blisters and calluses. The reason it says possibly is because we've talked about if a blister is not a large blister, if it's a very small area, and it's not a I'll say a bulbous blister, so it's a very small, close to the skin blister, then it would probably heal best on its own if it's not at risk of popping. If the blister is at risk for popping, then you want to go ahead and debride it off because you don't want that blister to pop and then to have an area where bacteria could be trapped under that skin. You want to go ahead and debride that off and start doing some good wound care on that wound bed that's left. By the same token, calluses, and when we talk about neuropathic wounds, we'll talk a lot about calluses because in the diabetic, because the turnover of the skin cell or the skin layers doesn't happen in the same way, it's very much slowed. You get a buildup of a lot of tissue or a lot of dead skin layers. And so a callus can actually cause maceration to underlying layers of skin. The more callus buildup you have, the more maceration, the more fluid and wet and macerated that tissue underneath stays. So there are times where the callus needs to be debrided off so that the tissue can start to heal and can have a normal fluid level. And again, we'll talk more about that in neuropathic ulcers because that's especially prominent on the feet of diabetics. Another indication for debridement is if there's a residual topical agent. It's no longer on the market, but there used to be this topical agent, antibacterial agent that you would put on a wound that was called Panafil, and it was green, and the green was chlorophyll. So you used it not only for bactericidal effects, but it also would control smell. So if there was a significant wound odor, you'd put this Panafil on the wound, and it turned everything green. So you can imagine, you clean the wound, you put the Panafil on it, you put a clean dressing on it, send the patient away, they come back a couple of days, you take it off, everything on this wound is green. So you really couldn't see, was there infection? Was there, what was necrotic tissue? What wasn't? So sometimes with debridement, so you're not only cleaning that wound when you first take that old dressing off, you're not only cleaning the wound thoroughly, but you may need to debride some of that residual topical agent, actually debride it off so you can see what's real and what's not under that topical agent. There's another type of topical agents that used with burns, and we'll talk about that when we get to that. But it's a creamy white topical agent. And again, when you take that old dressing off, a lot of times you're just left with a lot of that topical agent, so you really can't see what the wound's doing. And so you may need to debride some of it off just to see what's going on underneath that tissue. And then finally, for the red, yellow, black system, we always want to debride black eschar, especially if it was a full thickness black eschar, we want to debride that off. We want to debride any kind of yellow slough. We do not want to debride a red granular wound. That will be a contraindication to debridement. If you have a red granular wound, that's what we want. We want granulation tissue. In the red, yellow, black system, the wounds are going to present with a combination of black, yellow, and red. If your wound is all red, there's no reason for debridement. So it's only if you have the yellow slough or the black eschar that you want to do debridement. All right, so here is a table that kind of talks about the treatment goals. So if you have a red wound, it's pale pink to beefy red with granulation tissue, your treatment goals, all you want to do is to protect that wound, maintain that warm, moist wound environment, and protect the peri-wound area. Make sure it doesn't get too wet or have any kind of swelling, edema, any of that kind of thing. So this table is really important for you guys to look at and to really make sure that you understand. This goes back to some of the things we've already talked about. The basic tenets of good wound care is maintaining a warm, moist environment. So if you have beefy red granulation tissue in a wound bed, 100% beefy red granulation tissue, your treatment goals are just to protect that wound, maintain that warm, moist environment and the peri-wound area, and let it heal. Let the body heal it, because it will. You'll start to see the epithelialization and the closing of that wound. So if your wound bed is yellow, it has this moist yellow slough. It varies in adherence. We're going to talk about, when we talk about venous insufficiency ulcers, they often have a yellow slough that's incredibly adherent, meaning it is really difficult to debride it off. It sticks like glue to the granulation tissue. But the treatment goal is going to be to debride that, because that's necrotic tissue. So you want to debride that necrotic tissue. You want to absorb any drainage that you have going on. Again, we want a moist environment, but we don't want a wet environment. So you want to absorb the drainage, and you want to protect that peri-wound. Again, you want to protect it from any maceration over, an abundance of drainage. You want to protect that peri-wound. And with the black wound bed, if there's a thick black adherent eschar, you want to debride it. Your number one treatment goal there is to get that thick black eschar off of there. So you want to debride that necrotic tissue. Here's a picture of a red, yellow, black. So you can look at that and see we've got, you can see some eschar. You can see a little bit of slough. And then on the very edges, you can see some of the granulation tissue. Okay, so just look at this and estimate the percentage of red, yellow, and black. Now, I will tell you that this, obviously this is a subjective thing, but if you were to look at this wound and I asked you to estimate the red, yellow, and black percentage, if you told me that it was 50% red, I'm going to have a problem with that. So within reason, this is subjective, but there's also a reasonable estimation. Okay, so if you were to say that it was maybe 35% eschar and maybe 40% slough, yellow slough, and then let's see, what did I get? 75%, and then maybe 25% red granulation tissue. Honestly, I don't know that I would argue with you on that one. To me, it looks more like 15%, but again, very subjective. So as long as you're looking at the wound and being reasonable about estimating the red, yellow, and black percentage, this is subjective, but it gives you a good idea. If I were to read your note and you were to tell me that it was 35% eschar and 40% slough, I'm going to have a visual image in my head of what that wound looks like, which once I take the dressing off, it's not going to be too far off. Okay. All right, so what are the contraindications for debridement? I've already talked about one. If it's a red granular wound, there is no reason to do any debridement. That's what we want. We want red, beefy red granulation tissue. On heel ulcers, one of the most common types of pressure ulcers we're going to see is a heel ulcer from an elderly person laying on the bed, laying supine with the pressure on their both of their heels. We do not debride the heel ulcers because there's going to be a thick black eschar, and if there's no edema, erythema, fluctuance within the, it's not boggy, there's not drainage, that kind of thing, you leave it alone, because essentially what we found is that eschar, if it's dry, it's not swollen, it's not boggy, it serves as a protective coating. Only on heel ulcers, though. This is the only one that we talk about as a contraindication for debridement. And again, only if it's not wet and swollen and what we call boggy, so that when you press on it, the tissue is just you kind of sinks down. There's no real turgor there. So only if it's a stable heel ulcer would you leave that eschar on there and not debride it. Wounds that are going to require surgical debridement, you don't start on any other kind of debridement if it's going to do surgical debridement. And the reason being is that when they go in and do a surgical debridement, they put the patient under and they do a lot. They cover a lot of area in a small period of time. There's no reason to do any kind of smaller debridement, more selective debridement, if there's going to be a surgical debridement, because again, the surgeon's going to have the patient under anesthesia and they're going to get the whole thing cleaned at one time. And then electrical burns prior to physician assessment. The reason for that, and we'll get to that when we get to burn, but electrical burns are tricky in that the entrance wound and the exit wound, there can be a whole lot of damage in between. And until that physician has looked at it, you don't want to start debriding off anything around that electrical wound, because it may get a whole lot bigger than you could possibly handle with just a typical debridement. Again, because electrical burns can be so much, it's kind of like an iceberg. I'll just make that analogy. You may only see a small tip and think, oh, it's only this, but then once you start getting into it, it is huge at the bottom, because electrical burns can cause a lot of damage of surrounding tissue. So there are contraindications unless the physician has assessed it and does order debridement. All right, so when we're looking at doing debridement, there's some things that we want to take into account. Mainly what we want to look at is we want to look at what the wound looks like. Again, if you go back to that wound we had a minute ago, the picture of the wound we had a minute ago where it was on the heel, and you had some red, you had some black, you had a very little bit of red, you had a lot of black, a lot of yellow. What are the characteristics of that wound? What is it? Is it dry? Is it wet? What does it look like? What is the status of the patient? Is this patient really malnourished and not in very good health? Or is this patient in pretty good health? They're pretty mobile. They're doing pretty well. And you could probably just debride a little bit of that necrotic tissue on there and they'd be on their way, and maybe they just start healing because they're in pretty good shape. You also want to know what are the existing practice acts in your state. Okay, in many states, nursing cannot do debridement. Physical therapists can do debridement with training and a documentation of that training. One of the things that we're going to do when we have the integumentary lab is you guys are going to do a debridement lab, and we're going to have you check off some things, and then I'm going to sign off on it so that it will show that you've had some training in debridement. And then finally, the clinician's knowledge and skill level. A lot of times people are very intimidated by debridement, which is good. They should be. You should never rush into anything when you're talking about using a forceps and scissors and a scalpel. You should never rush into anything that you don't know what you're doing. I already told you guys the story of the physician who came in over the weekend and debrided the gentleman's anterior tib tendon because it was a dry tendon and it was very fuzzy and he couldn't identify what the structure was. was. So he debrided it out of there. The patient told us that he debrided all that cotton that was in my leg. Well, it wasn't cotton, it was his anterior tib tendon. So of course that patient then, as I said, became an amputee. I'm not sure if I told you the rest of the story. That patient was very happy with an amputation, which I know when you hear that, you're going to go, what? He was happy because the wound that he had on his leg was painful. And it had been there for quite a few months. And once he had that amputation above the wound site, it healed pretty quickly. He got a below knee prosthesis and he was up and about, versus he had been in a chair for many months non-weight bearing while we were trying to get that wound to heal. So for him it was a better outcome. But it's really important that your knowledge and your skill level is where it needs to be before you start debridement, meaning you need to be able to recognize not only the characteristics of the wound, but also the structures within the wound bed that you're looking at. All right, so when you're preparing to do a debridement, you want to use standard precautions. By now, I think you guys probably know what standard precautions are. You want to, depending on what the wound looks like, at the very least, you want to have a gown and gloves on, at the very least. And then you want to explain the procedure to the patient. This is incredibly important. The reason this is so important is that if I come toward you with a scalpel and scissors and forceps, how are you going to feel if I haven't told you what I'm about to do? You know, you're going to feel like you're in the movie Halloween, you know, or Jason's coming after you. So you want to explain the procedure very thoroughly to the patient before you start, so that the patient won't be fearful. They'll understand what you're going to do and why you're doing it. That's the other important thing. The patient has to understand why you're doing this. All right, so here's a box that talks about steps to prepare for the patient for debridement. First of all, you want to get all your equipment and your supplies together. All right, you want to make sure the patient's comfortable, so that the patient's comfortable, but also so you can visualize the wound bed. Sometimes maintaining the position so that you can visualize the wound bed is a little more difficult. If you think about a wound, for example, on the ischial tuberosities, it's sometimes more difficult to keep the patient in the position you need to have them in so you can visualize the wound bed. So that's why it says an aid may be needed to assist with this. You always want to use proper posture and body mechanics. Because this is incredibly fatiguing. You're going to be bending over this wound, and you want to make sure that you have the best possible position and body mechanics that you can possibly have. You want to make sure it's well lit. You want to have wash your hands, have clean gloves on, remove the old bandage and discard according to whatever facility policies there are. Generally, it's going to be in a red bag because it's probably going to have some kind of discharge on it, some kind of drainage. And this is really important, once you take that old bandage off, you then must take your gloves off because your gloves are soiled, right? Because you've now touched an old bandage, you've taken off an old bandage, so those gloves that were clean before you remove that old bandage are now soiled. One of the things you really have to maintain is a high level of cleanliness with wounds. So you can't change your gloves too many times. So I wash my hands, put on clean gloves, take off the bandage, discard it, and then discard the gloves that I used to take that bandage off and put clean gloves on. Once you've got clean gloves on, you can start looking at the wound. You can see how much red, how much yellow, if there's eschar, if it's wet or covered with some kind of topical cream or something. You want to clean it. It says it may need to be irrigated, just so that you can see exactly what's going on with this wound. All right, so you've now looked at the wound, you've cleaned it, you've got a good idea of what's going on. You want to remove those gloves again, okay? as I said, you can't be too clean with your gloves. Anytime you do anything with that wound, take off that pair of gloves and put on a new pair of gloves before you go to the next part of the wound care. So you're going to remove the soiled gloves. You're going to explain to the patient what you're about to do. Tell them what you're seeing in the wound. Tell them why you're debriding. Tell them why this is important. Those 7 things that we just talked about. You can educate the patient on that. You can tell them this is why we need to do this. We need to get this non-vitalized or devitalized tissue out of there so the wound can begin to heal. So you're going to explain it to the patient, then you're going to put clean gloves back on, and you're going to start your debridement technique. Here's the methods of debridement that we're going to be going through. There's sharp, autolytic, enzymatic, mechanical, biological, and surgical. We'll go through each of these. I've already talked about selective and non-selective and which ones are sharp, autolytic, and enzymatic or selective, meaning that you are looking at specific devitalized tissue that you're taking off, okay? Whereas a non-selective, such as mechanical and surgical, you're taking off all of the tissue. You want to get devitalized tissue, but you may get vital tissue with it because it's a non-selective debridement. You're not just picking out the devitalized tissue, you're taking off a layer, if you will, of all kinds of tissue. All right, so sharp debridement is what we're going to be practicing when we do on our integumentary lab. Sharp debridement is where you use forceps, scissors, and sometimes you use a scalpel. Again, when we do the lab, I'm going to teach you cross-hatching. If you have an eschar, like a very thick eschar or maybe a thick callus, you will need to use a scalpel to cross-hatch. That is the only time you use a scalpel. Scalpel is not used frequently in sharp debridement. The 2 tools that you're going to use most frequently in sharp debridement are the forceps and the scissors. Sharp debridement is the fastest and most aggressive form of debridement because, again, it's selective. So you're going straight to that devitalized tissue, and you're getting it out of there. It can be performed by PTs where allowed by the law, but it does require a doctor's order. So if you get an order for wound care and you do the evaluation on the wound and you determine that debridement is needed, then you do need to make sure that the physician is called and there is an MD order for sharp debridement. So when do you want to do sharp debridement? Well, if you've got a large amount of necrotic tissue, you've got a callus, you've got an advancing cellulitis, sepsis, or eschar. Any kind of necrotic or necrosis that you see in a wound is when you want to do sharp debridement. Sharp debridement can be used on wounds with any amount of necrotic tissue, meaning if I have just a little bit that I need to clean up or if I had a lot that I need to clean up. Sharp debridement can also be used on chronic wounds. There may be devitalized tissue there that has been there and has not been cleaned off, and once you do that sharp debridement and clean it off, that chronic wound suddenly becomes an acute wound, and the amount of wound healing just takes off because it was chronic just due to devitalized tissue. Okay, what are the contraindications to sharp debridement? Well, the number one contraindication is when the area cannot be adequately visualized. Remember, we talked about a wound that had depth to it. I'm not going to reach down into a wound that has depth that I can't see and start trying to pull out necrotic tissue. If I can't fully visualize that wound bed, I am not going to debride it. So if there's any depth, if there's any undermining, if there's any tunneling, I'm not going to be debriding in the areas of the undermining. Again, I can't see it. So I don't know when I'm trying to do a sharp debridement and pull out devitalized tissue, I don't know what I'm pulling out if I can't see it. So that's a contraindication for sharp debridement. If you can't identify what you're debriding, don't debride it. Again, we'll go back to the one I just told you about. If the physician did not know that what looked like cotton was not in cotton, but was indeed the man's anterior tib tendon, there should not have been a debridement of it. If you can identify it, do not debride it, because it may be non-vitalized tissue that is really important, very dried tendon, any number of things that you could be debriding out. If you can identify it, don't debride it. If you don't feel competent doing debridement, then say, I don't feel competent doing it, and don't do sharp debridement. And then the last one is, if you have an ischemic ulcer, meaning there is not good blood flow to the ulcer itself, so it has a low ABI, ankle brachial index, meaning there is not good blood flow to that, good perfusion to that area. It's an ischemic ulcer. It is caused because there's not good blood flow and is infected. You do not want to debride that, because there's not enough of the body's own protective mechanisms, because you don't have that good perfusion. There's not enough of the body's own protective mechanisms for you not to cause additional infection, because it is an ischemic ulcer and it is already infected and there's a low ABI. You would not want to debride that type of wound. You want to be really cautious if someone is immunosuppressed, thrombocytopenic, or they're on anticoagulants. So immunosuppressed or thrombocytopenic, again, you're going to, if there's infection there, or even if there's the risk of infection, if they're already at a point where the body can't fight it, you don't want to debride and risk spreading infection. If they're on an anticoagulant, they will bleed profusely if you do sharp debridement. Now, I have done sharp debridement on people on anticoagulants, quite a few people on anticoagulants, but you have to be very, very careful and very judicious in the amount of sharp debridement that you do. You're not going to go in there and start slashing everything. You're going to do very small amounts of sharp debridement at a time, because you do not want to cause a large episode of bleeding because this person's on an anticoagulant and you've over debrided them. If wound closure is not consistent with the plan of care, so you're looking at a wound and the closure it's not closing the way that it's supposed to, or it's not closing in the time amount that it's supposed to as far as the plan of care, you want to be very careful about sharp debridement. Okay, and also you never want to debride hypergranular tissue. We talked a little bit about hypergranulation. We talked about how you take care of it with a silver nitrate stick. You do not debride it off because it will bleed profusely. When do you stop sharp debridement? When you fatigue, you need to stop, because the more fatigue you have, the greater your risk of slipping and causing damage. So my general rule of thumb is, and what I always told therapists, is never debride more than 15 minutes. 15 minutes is a long time to be debriding, because debridement, and you guys will see this when we do the integumentary lab, you've got your head down, you're in a bad, it really is not a good posture. You're focused on the tissue that you're debriding off. So 15 minutes can cause quite a bit of fatigue. If the pain is not adequately controlled for the patient, you do not want to do a sharp debridement. Another story I have, it seems I have a lot of bad doctor stories when it comes to debridement. Had a lady that was in, this is when we had, big whirlpool room, and she had been coming down for whirlpool. She had a wound on her foot, specifically on her great toe. And we had been working with her and trying to get the wound to heal. The physician came down and didn't like the way that the toenail looked. So he asked for some instruments. He grabbed the toenail and he literally ripped it off while she was in the whirlpool room. This lady screamed so loud that there were people from down the hall that came running trying to find out what was going on. This woman's pain was not, he gave no, we could have given a lidocaine gel, we could have given anything to try to numb her a little bit. This physician gave no pain control whatsoever. He simply took the instrument and ripped the nail off. So her pain was not adequately controlled. She should not, that debridement should not have been done in that whirlpool room, and it should not have been done in that manner. You also want to terminate if you see a decline in the patient's status or their tolerance to the technique. So if your patient's not with you, they're not alert, you see them starting to fatigue themselves, or just telling you how much it hurts and they can't take it anymore, you stop. You terminate the sharp debridement right there. Again, if you start to see extensive bleeding, let's say that maybe the person's on an anticoagulant and you didn't know it, or let's say that they've had a surgical procedure very recently and you happen to have hit something and you have extensive bleeding, you terminate immediately. You terminate the sharp debridement and you get pressure on it. If you're debriding and you see a new fascial plane, meaning you've moved from one layer of tissue to another one, you stop. You stop the debridement when you get to the new fascial plane, because you want to know. Remember, we talked about you never want to debride anything you can't identify. And if you've gotten to a new layer or a new fascial plane, there's going to be structures there that you need to stop debriding and just take a good look at what's going on. And then finally, and I've already talked about this before, if there's nothing left to debride, if it's red, beefy red granulation tissue, a beautiful wound bed, there's no reason to debride them. So you would stop sharp debridement at that point. You can do serial instrumental debridement. We see this a lot with the venous insufficiency ulcers. Remember I talked about there's a different type of slough that you'd see on a venous insufficiency ulcer. It's very adherent. It's a very yellow, and it's very close to the granulation tissue. And so it's hard to get it off because it's really adhered, but you need to continuously debride this yellow slough off so the granulation tissue will continue, and so you can encourage epithelialization of the wound, and that's called serial instrumental debridement or a maintenance debridement, just keeping that slough, keeping that adherent slough off of that wound bed so that it'll start to epithelialize. Selective sharp debridement should be performed only by a PT, not by a PTA, and you're going to want to get your hemostatic agents and your topical pain medications handy. So in other words, if I happen to hit something that it bleeds quite a bit, I'm going to need to have something there. Styptic, the guys may know when I say a styptic pencil, something that's going to stop that bleeding. Silver nitrate will also stop bleeding. Or if I've got a patient that's incredibly painful, incredibly sensitive, then I'm going to want to have a lidocaine gel or something that I can put on that wound and let it sit for about 15 or 20 minutes before I start doing that debridement, because you do not want that patient screaming in pain while you're doing debridement. I will tell you, when we talk about selective sharp debridement performed by a PT only and not a PTA, in Virginia, there have been a couple of PTAs who are wound care, who did get their certification as wound specialist, and they did go to the board of PT and request a special ability to perform wound care, and it was there was a hearing and sides were heard, and they were not allowed to perform the selective sharp debridement, despite the fact that they do have this specialty wound care certification. They were not allowed to perform selective sharp debridement. All right, so what's the procedure? Again, we're going to go over it. I'm going to say it. You're going to hear it verbally today, but next week when we do integumentary lab, you guys are going to do this. You're going to practice this. So you always want to keep your scalpel and your scissors parallel to the surface. You know, you're not going to have it perpendicular. You're not going to be stabbing them or that kind of thing. It's parallel to the surface because you're taking layers. You're taking thin layers of tissue off. You're not trying to slice it. You're trying to take very thin layers off. You're going to rinse it with saline and reassess it every time you debride something. You're going to rinse it with saline and reassess what more you need to do. We are going to do supervised practice, but you should always, if you decide that you ever want to do debridement, you should always do continuing education and keep maintain your competency in sharp debridement. There are certifications. There is through the American Wound Management Association. There is a CWS, it's called, or a certified wound specialist that is open to PTs. It's open to podiatrists. It's open to a number of healthcare professionals. So if you are interested in a certification in wound management, it is a exam that you take. And I don't remember the price on the exam now. I can tell you that I was one of the first groups when the certified wound specialty was developed. I was one of the first groups in the country that was granted a CWS. I maintained my CWS for 10 years, and at the end of the 10 years, it was time for recertification. At that point, it was going to cost about anywhere between $400 and $600 to take the exam, the certification. So I decided at that point that it was not worth paying the money to take that exam. I still had the knowledge in my head. I just don't have the CWS behind my name. So it is going to be, if you're interested in a certification, it is something that you can check out, and they have all kinds of continuing education courses you can take and can ready you for that exam. And it is I believe it's a 4-hour exam. It may be 6 hours. All right, here's an example of what we're going to be doing. You see they're holding the scissors flush with the patient, which is the orange in this case, because you don't want to pierce them with the sharp end of the scissors. We will be debriding an orange as well in integumentary lab next week. This is a ham hock, or actually this is a pig's foot. This is a pig's foot. So when you're debriding with a scalpel, you want to hold it level with the tissue because you don't want to cut into deeper healthy tissues. Okay, you see how if you can see what they're doing with their left hand, they're taking the forceps and they're picking up the devitalized tissue, and they're taking the scalpel and they're slicing very thinly, very thin layers, and you do it parallel to the surface of what you're debriding. Okay, so it's really important you go parallel to the surface so that you're not going into deeper healthy tissue. This is what I talked about a little bit earlier, cross-hatching, which we will do when we do the debridement lab. So you cross-hatch, you score the eschar and the necrotic lines, so it helps you, well, there's a number of things that you can do by cross-hatching. Number one is that if you cross-hatch eschar, you can then the topical antimicrobial or the topical debridement creams that we have can then get into the eschar and soften it even more and help you to, the next time you see them, debride even more. But when we start debridement, when you cross-hatch, it's to help you be able to get underneath that necrotic tissue and pick it up with your forceps and your scissors. This is an example of a wound that would need some debridement. If you look at the circle that's immediately atop the foot, I'm guessing that's about between the 3rd and the 4th metatarsal. The great toe is gone, and that's why you're looking at this going, wow, you really don't see too much of a shape here. This is a classic neuropathic foot. These are neuropathic wounds. This is a Charcot foot. As you can see, if you look at the medial arch, there is none. It's absolutely completely collapsed. The bone structure for the medial arch and the longitudinal arch of the foot is completely collapsed. The great toe is gone, and then you see a wound right around between the third and the fourth metatarsals. So you would need to debride that off. You also see a lot of callus around there. This is what I was talking about with neuropathic wounds. You see a lot of callus formation. You do notice where that great toe is gone that there seems to be some sort of a wound there. But again, it's calloused over. So you need to debride that callus off to find out what is underneath that. Is that a wound that needs to close and it can't close because it's now calloused over? So you would need to debride that callus off to find out what's going on, what kind of wound bed or wound you've got underneath there. And that's what it looks like after you debride it. Okay, so as you can see, once you where that great toe was, once you debride it off, there's really nothing there. It's all clean, it's healed. You just needed to get that callus off of there. And then if you look at the wound between the third and the fourth toe, you can see once it's debrided and some of that callus is debriding off, there's actually some beefy red granulation tissue in there. You can also see it's white and macerated, which means there's a lot of drainage coming out of that wound. So you would need to control some of that drainage so you can help that wound to heal. All right, autolytic debridement. Autolytic debridement is when the easiest way to talk about autolytic debridement is when you let the body debride itself. So endogenous enzymes digest necrotic tissue with a moisture retentive dressing. So basically what you do is you put I always make the analogy of a terrarium. If you guys know what a terrarium looks like, it's, you put a bunch of plants and soil in a glass container and you close it. And that container, there's moisture that's in there, and that terrarium, those plants tend to grow because of the moisture that's created within this closed environment. Autolytic debridement is the same thing. So you're going to put a moisture retentive dressing and there's a number of moisture retentive dressings, but I'm going to use one that's really simple for you guys to think about. Saran wrap. If you take saran wrap and wrap it around your arm and leave it there for a period of time, once you take that saran wrap off, what's going to be underneath it? It's going to be moist. It's actually going to be wet. So that's autolytic debridement. It's the least invasive, it's the least painful method, and it's really, really easy to teach. Now, one of the things that is incredibly important about autolytic debridement is that the patient has to be healthy enough for the body to actually have those endogenous enzymes. If the patient is malnourished, or there's a lack of blood flow, you're not going to have those endogenous enzymes because the body is not healthy enough to actually to have the presence of endogenous enzymes. It requires minimal time to perform, but it does require time for the debridement to occur. So this is not, autolytic debridement is not a rapid thing. When we talked about sharp debridement, we talked about it being the fastest form because you get in there, you take out that devitalized tissue, you cut it off, and you throw it away, and you're done. With autolytic debridement, it takes weeks to fully debride a wound off with autolytic debridement. But again, it's more selective because the body's only debriding off devitalized tissue. The other point about it is as long as that wound is covered with that moisture trapping dressing, you're not going to be able to visualize that wound, because every time you open it, you're going to air, you're going to decrease your autolytic debridement. So it's something that you have to be able to close it up, leave it there. Couple of days, they come back, you open it back up, you clean the wound, and you put another moisture retentive dressing on it, and you send them back for 3 or 4 days. Um, any wound that has necrotic tissue can would be a good indication for autolytic debridement. If a patient cannot tolerate other forms of debridement, let's say maybe sharp debridement is just too painful and they can't tolerate it, then autolytic debridement is a good alternative for them. It is commonly used in the home health setting or a long-term care setting, again because it's the body debriding itself. So it takes a little bit longer, but it's also very selective, and it's the body debriding itself. It's those endogenous enzymes that are only debriding devitalized tissue. What is contraindicated? Any wound that's infected, and I'm going to say this about 3 times. A contraindication to autolytic debridement is a wound that's infected. You never want to close up an infected wound. If you know it's infected or there's a deep cavity, you don't want to close it up with a moisture retentive dressing. So autolytic debridement, one of the major contraindications is an infected wound or a wound with deep cavities. If you know that already know that the wound needs sharp or surgical debridement, you also wouldn't close it up and start doing autolytic debridement. When do you stop autolytic debridement? After the wound bed's clean. You know, if it's like anything else. If you're using these moisture retentive dressings and, you know, they've been coming for a couple of months, and you take that dressing off the next time they come and you clean that wound up and that wound bed is clean and beefy red, there's no reason to do autolytic debridement again. And so we talked earlier, if that wound, you take that moisture retentive dressing off, that wound is clean and beefy red, what do? You just protect it and keep it moist and let it heal. That's all you need to do once that wound bed is clean and beefy red. If you're doing autolytic debridement and you don't see a change in that necrotic tissue, so you're not seeing a decrease or a decline in the amount of necrotic tissue, again, as I said, there's sometimes that people aren't healthy enough to do autolytic debridement. So there's not enough endogenous enzymes in their body, or they're not healthy enough for the body actually to debride that necrotic tissue. So that's another time that if you're not seeing changes, remember we talked about within 2 weeks, if you're not seeing the changes you need to see within that wound, then you need to reassess. So what's the procedure? Well, with autolytic debridement, you want to crosshatch the eschar. If eschar is there, you want to crosshatch it. You want to open it up so that that moisture can get down into that eschar. Those endogenous enzymes can begin to break down that eschar. You want to put that moisture retentive dressing on there. You want to keep it on for 72 to 96 hours, and you want to protect the peri-wound. Why? It's a moisture retentive dressing, so that means that it's going to be moist, that the skin around the wound is going to be exposed to a very moist environment. So you want to make sure you put a protective layer on it so that you don't macerate it and cause the wound to be even bigger. Here's a hydrocolloid, which is an example of a moisture retentive dressing. As I said, you'll see this a lot in nursing facilities. They use a lot of hydrocolloids. Enzymatic debridement is when you use an enzymatic or chemical debrider. It is a form of selective debridement, requires a physician's prescription. Right now, the only enzyme that's currently FDA approved is collagenase. There is the brand name of the debrider is called Santyl, S-A-N-T-Y-L, and it is a collagenase. So as the name, if you break down the name of that, what it means is it breaks down collagen. So collagenase breaks down collagen. A lot of the yellow slough that you see are dead, devitalized collagen fibers. So a collagenase breaks those collagen fibers down so that you can wipe them off and get to a clean wound. And that's enzymatic debridement at its finest. It requires less skilled and sharp or surgical debridement. It's less painful than other methods. It can be expensive because Santil, those collagenases are expensive. There used to be another one on the market called Accuzyme, but every now and then the FDA decides, for a while they decided Santil wasn't something that needed to be on the market, and they took it off for a few months and then they put it back on. And Accuzyme was the only thing you could get. Well, now they've decided maybe Accuzyme is not the best thing that you should be using, so they've taken it off the market. The enzymatic debriders and the FDA tend to kind of go in circles, and so at any given time, you have to find out what's in the market as far as an enzymatic debrider that you can use. But it can be expensive because, again, these topicals are pretty expensive to use, and it may take a period of time so that you're using a lot of that enzymatic debrider. The indications are for infected and uninfected wounds with necrotic tissue. Now, this is one of the ones where you can use enzymatic debrider on an infected wound. The enzymatic debridement itself is not going to spread the wound. It's not spread the infection. It's not going to cause the infection to get worse. It's simply going to break down that devitalized collagen fibers so that you can start to clean the wound. It's appropriate if the patient cannot tolerate sharp debridement, and it's also appropriate in home or long-term care. What's contraindicated? Well, wounds with exposed deep tissues. You never want to put a collagenase on an exposed deep tissue. So when you've gone beyond the fascial plane, down into the beyond the dermis, down into the deeper tissues. You don't want to put a collagenase or enzymatic debrider on a facial burn. You don't want to put it on calluses. And you don't want to put it on a wound that's free of necrotic tissue. What is that? A beefy red granular wound. There's no reason to put any enzymatic debrider on a beefy red granular wound. If it doesn't have necrotic tissue, there's no reason to put it on there. Exogenous enzymes should not be applied to wounds being autolytically debrided. Okay? So, in other words, you shouldn't use an enzymatic debrider if you're then going to close it with a moisture retentive dressing. It's just not a good idea because you're not going to be able to see what's happening underneath that moisture retentive dressing. So that's not safe to do. When do you terminate? Once you've debrided the amount that you want to debride, once it's a clean, beefy, red wound. Or, as we talked about before, if you're not making progress within 2 weeks, if you're not seeing that enzymatic debridement work, then you need to reassess and find another intervention. Here's the procedure. You're going to follow the manufacturer's guidelines on that enzymatic debrider. You're going to need a physician's prescription. You're going to crosshatch. You're going to keep a moist environment and make sure that whatever dressing you're putting on there, it maintains a moist environment. You're always going to observe the wound for infection, and you're going to use a topical antimicrobial therapy as needed. Remember, we said that infected wound was not a contraindication for enzymatic debridement, but if you do see infection, you're going to want to get a topical antimicrobial therapy on there. Mechanical debridement is when you use force to remove devitalized tissue, foreign material, and debris. The most common form of mechanical debridement is a wet to dry dressing. I'll say that again. The most common form of mechanical debridement is a wet to dry dressing. It's non-selective. You're taking off many different types of tissue, not just the devitalized tissue. You can see here in this little box underneath, there's wet to dry dressing, the pulsatile lavage, whirlpool, hydrogen peroxide, wound irrigation, wound cleansing, and scrubbing. All forms of mechanical debridement, which is a non-selective form of debridement. Here's how you apply a wet to dry dressing. You get a saline moistened gauze. You crumble the gauze first, you moisten it with saline, crumbled, you put it in the wound bed, okay? Close it up, allow it to dry, and then you rip that gauze away. When you rip that gauze away, the theory is that devitalized tissue is going to stick to that gauze, and when you rip it out of that wound bed, that devitalized tissue is going to come with it. Well, the reality is that new young granulation tissue is also going to come with it, and that's why it's non-selective debridement. This used to be what every physician will order. It was an automatic order for wet to dry because truly they didn't know what other options were there. And even now in hospitals, nursing homes, you'll see a lot of orders for wet to dry dressings when there really are much better alternatives out there. So it used to be the standard dressing that every doctor ordered. Again, now many better options, and it's only indicated for wounds with 100% devitalized wound bed. You never want to use wet to dry if there's any granulation tissue whatsoever in there, because it will rip away young granulation tissue. When you're talking about scrubbing, use a high porosity sponge or brush or a gauze in water or saline. This is contraindicated for granulating wounds. Again, you can scrub away some of that young, immature granulation tissue. This is best used for highly contaminated superficial wounds. We had a gentleman that used to come in and see us once a year. Gentleman, I say, he's young, early 20s, and he had psoriatic arthritis, and he had psoriatic arthritis over his whole body. It covered his whole body. So we would put him in the huge Hubbard tank, which was the largest one we had. It had a stretcher that he would get on the stretcher, and we'd lower him into this huge Hubbard tank, and then take a surgical scrub brush and scrub him because his body was covered with these psoriatic lesions from the psoriatic arthritis. And the only way, the best way to get him clean the fastest was to simply do this scrubbing, this mechanical debridement with him in the whirlpool or in the Hubbard, the huge Hubbard tank. It generally would take, like I said, he came to see us about once a year, and it would generally take us about a week to get him cleaned head to toe of all these psoriatic lesions on his body. Another type of mechanical debridement is using a wound cleanser. There's many different types of wound cleansers, and basically it comes in a spray bottle, and it contains surfactants and cytotoxic agents. These wound cleansers are not regulated by the FDA, and it can cause you can get non-selective removal of anything, any kind of debris, any kind of loosely adhered tissue even, because when you spray this wound cleanser, there is a mechanical force behind it that, coupled with the surfactants and the cytotoxic agents that's actually in it, will cause removal of devitalized tissue, but also, again, young granulation tissue can be removed as well. There are better treatment options. This is something that used to be used quite a bit in long-term care facilities. They used them for pressure ulcers quite a bit. You can use it for if you have like a, you fall on the pavement and you do a huge scrape, acute scratch, you can use a wound cleanser for that. You should not ever use wound cleansing for a long-term use. Biological debridement, okay, this is where most of you are going to start squirming, also known as maggot therapy. There are two types of maggot therapy, and yes, I have used it multiple times in my practice. There's two different types. There's contained and there's free range. So what is meant by that is, with contained maggot therapy, you literally order a dressing. It's a square dressing that comes with maggots on it. You place it over the wound, you close the wound up. They come back in a couple of days, you open it up, and that is the cleanest wound you have ever seen in your life. All that's left is beefy red granulation tissue, because the maggots will only eat the devitalized tissue. They will not eat beefy red granulation tissue. So the free range that's mentioned here, and we had multiple times we would have patients come in with this, especially if you're in a very rural environment and it's very hot in the south. People can come in with, you take their dressing off and their wound bed is covered with maggots. At some point, somehow a fly's gotten in there, he's laid eggs in there, and then you have maggots. I know you're cringing, and I know everybody's wiggling in their seats, but I will tell you that was the best thing in the world for a wound. When you take that dressing off and you see those maggots, that is a clean wound, because those maggots are just so efficient in getting every single bit of that devitalized tissue that's in that wound, and again, leaving it beefy red. So, when it happened, when we had a patient that came in, you took off the dressing and you saw the maggots, you were like, oh, great, we have got a clean wound, because that is the best. Biological debridement is truly one of the best forms of debridement. But most people do not, it says seldom used in the U.S. Most people don't like to think about that. Most people will squirm in their seats, just like as I'm sure you guys are right now. It is FDA approved live medical device for debridement. Again, I have used the contained maggot therapy. We've had physicians that have ordered maggot therapy, and we order the contained maggots. Again, they do a beautiful job. But more often than that, we see people that just come in with the free range maggots. So they're out in the again, in a rural environment, it's hot outside. They're outside a lot. They're not in an air conditioned environment, and they get maggots in their wound. And again, very, very clean debridement. So the larvae release enzymes that degrade necrotic tissue. They then ingest the necrotic tissue and the bacteria. They are unaffected by antibiotics. They're faster than autolytic and enzymatic debriders. They are just really efficient little critters, and they just eat that necrotic tissue like there's no tomorrow. It may decrease the odor and exudate. I know that sounds contrary. You think maggots, you think, oh, it's got a stink. It doesn't. Again, these are clean wounds. They're beefy red. And generally you don't have a whole lot of exudate. You don't have a whole lot of drainage. You don't have a whole lot of odor, because it is really a clean wound. And it may increase the granulation and epithelialization, because it's going to move that wound on down the road of the next phase that it needs to go to, because it's cleaned out every bit of that devitalized tissue in there. Surgical debridement is when a physician or a podiatrist takes the patient in, and they put the patient under anesthesia. They use a scalpel, scissors, or lasers in a sterile environment. They can do extensive exploration of the wound bed, and they can do debridement of deeper structures with surgical debridement. Indications are cellulitis, osteomyelitis, which is when you have an infection that goes into the bone, extensive necrotic wounds, or undermining. Also, when you have necrotic tissue near vital organs or structures. A good example of this is I had a student that came back to report to me. She was doing a clinical affiliation at East Carolina University, and she was on the wound care team, and she had to do wound care on a patient that had a dehisced open heart surgery. So she was literally doing wound care right next to a pericardium, a pumping, an active, living heart. She said it was pretty intimidating, but she had some good training in wound care, and so yeah, they had gone in and done a surgical debridement after the open heart surgery had dehisced. They had gone in and done some surgical debridement, and then her job was to take care of the dressings and to assure that it healed. So surgical debridement near vital organs or structures does happen. Contraindications are patients who are unlikely to survive the procedure. Again, it is a surgical debridement, so if they are not a good candidate for surgery, then it's contraindicated. If the patient also is on a palliative care plan, they have cancer or something, so that they have 6 months or less to live, then again, surgical debridement will be contraindicated for them. So what they do is they go in and they can shave eschar. They can do an incision and drainage where they just open up the whole area, so that instead of, if you had tunneling or you had undermining, they can just literally cut everything off, so it opens it up into one large wound bed that can then start to heal. They can also do tissue biopsy if they're not quite sure, what's going on within the wound. And then always surgical debridement is followed by appropriate antimicrobial therapy. Here's a wound debridement algorithm. I'm not going to go through it, but this is something that you really, if you look at it, it's going to give you some really good decision-making tools. As you can see, anything on the right-hand side of this algorithm is a no. So when would you not do debridement is on the right-hand side of this algorithm, and when you would do debridement is on the left-hand side. So when you do debridement, it really is a collaborative effort because you do have to have the patient and the caregiver involved. They have to agree to the debridement. As I said, you have to have a physician order. You must have a physician order for debridement. Nursing has to be involved. Therapy has to be involved. Dietary, social services, and orthotists are often involved because, again, you need to make sure their nutrition is where it needs to be. You need to make sure that they're getting the services they need to get, so that if you're doing debridement of a person who's in a facility, they're getting what they need to get. And if there's a situation where an orthotist is needed, they also become a part of that team with the debridement. We talked about this a little bit earlier, so I'm not going to talk too much more about it, but you can see very large blisters here. You would want to debride those because the risk of them popping and becoming bacterial magnets is huge. So you would want to go ahead and pop those blisters and debride that upper skin off, and get a nice wound bed that you could go ahead and clean up. Here's another wound that, again, this one you're going to be a little more careful on. I am guessing by the amount of eschar that's on that wound that there's probably some osteomyelitis or bone involvement on this one. So you're going to be a little more careful in your debridement technique on this one. Some of the options you'd want to do on this one is sharp debridement. One of the options you would not want to do is autolytic debridement on this. I know you see a lot of eschar, but based on the amount of red that you see there may be active infection. Of course, we can't smell the picture, but if there was an odor, you would know beyond a shadow of a doubt you would not want to do enzymatic debridement on here. So the safest thing for this particular wound would be to do serial sharp debridement to try to get some of that eschar off and see what lies underneath.